As Kevin said, I work at the Center for Disease Dynamics, Economics, and Policy, and I'm also an assistant professor at Johns Hopkins. I'm going to talk to you today about the ecology and economics of antibiotic resistance. So I've got a number of slides. I'm going to try to go a little quickly through the first part. It's a little bit more of an overview of sort of the burden and the problems of antibiotic resistance, and then move into sort of the issues of how to deal with these problems. I'm going to start by talking about the problem of and the burden of antibiotic resistance and how it's growing. While we talk a lot about what this burden is, it's sort of a little bit unclear as to exactly what the magnitude of that problem is. So this is a recent CDC report. This was the big cover, which talked about that there were about 2 million illnesses related to antibiotic resistance and 23,000 deaths. And if you go down into the report, this is what they break down by the different pathogens. And so you can see that strep pneumo is about 1.2 million infections and causes 7,000 deaths, whereas methicillin-resistant Staph aureus causes about 80,000 infections and 11,000 deaths. And the question that comes out of this is, what is the best measure of this burden, though? I mean, is the number of infections or the number of deaths the most important thing? Or is the fact that you have something like CRE, which is carbapenem-resistant enterococci, which is causing a lot of infections now and it's starting to become a much bigger problem going forward? Is that a bigger problem? So how do we talk about what is the best measure of the burden? That was from the U.S. If you compare the U.S. to other countries, on the left we have the European Union, which has a population a little bit greater than the U.S. and has on average about the same number of deaths estimated, whereas Thailand has significantly more deaths per capita due to antimicrobial resistance. These are the best estimates that I could find. There aren't significantly more for many other countries at the moment. But if you look at the interesting thing here is you look at the societal costs. So for the EU, it estimates that there's approximately 1.5 billion per year in societal costs, whereas the U.S. estimates between 20 and 35 billion. Those numbers are not exactly similar. So if we go and understand where these come from, what does it mean societal costs? So for the European Union, they measure that there's extra in-hospital costs, so it's the extra costs for keeping someone in the hospital from having an antibiotic-resistant infection. There's extra outpatient costs. There's productivity losses due to absence from work and productivity losses due to patients who died from their infections. For the U.S., if you assume the CDC number of 2 million infections, that 20 billion that they estimate as due to antimicrobial resistance in terms of societal costs results in about 10,000 extra per infection. For Europe, that would only be about $750 extra per infection based on their numbers. But the CDC number is based on one single hospital in which they measured costs for 1,000 patients, and those costs ended up being about 3 to 4 million for the hospital, 7 to 9 million for mortality, some for lost productivity. So that's where they get those numbers from. So you understand, none of these numbers are exact, and it's not really clear as to exactly what the cost of resistance is, but it seems to be pretty large. So these are sampling of a bunch of other papers that looked at what are the excess costs for patients, and these are primarily patients in the hospital, for getting an antibiotic-resistant infection. And you can see that those numbers range from a couple $100 to many thousands of dollars. So this is a pretty big problem. What exactly the measure of the problem is may not be 100% clear, but it's a pretty big problem. And none of these actually consider other problems. So one issue is that kids get otitis media a lot, and they're treated a lot, and the drugs that are used to treat them have gone up significantly in cost over the last, so this is an older figure. It only goes up through 1996, but you can imagine it's pretty similar going forward. So these are the regular drugs that are used to treat kids, and what happens is that the regular drugs that they were using, resistance has emerged to a lot of them, and so now you're treating people with these more expensive drugs, even though the older drugs might still work. Everyone just sort of treats with the newer drugs. So you have additional costs associated with antibiotic resistance that may not even be captured by some of the regular measures. So we talked a lot about the burden in terms of the numbers. You can see that this is also a significantly growing problem, right? So this is E. coli resistance to a number of common antibiotics, and you can see that this is going up. And so this is off Resistance Map, which is CDEP website that we created. So you can go there and you can look at different drugs and bug combinations for resistance. So this is directly off that site. So you can see that resistance has been increasing for E. coli resistance. It's also been increasing for Klebsiella pneumonia. And the worrying one, obviously, is down here, which is the carbapenems, so this increasing resistance to carbapenems, to basically, which is one of our last line of drugs to treat these types of infections. And growing resistance is a significant problem going forward for those infections. This isn't also just a U.S. problem. This is also a global problem. So this is MRSA data from the CDEP's recent publication on the state of the world's antibiotics. And you can see that resistance to MRSA is a significant problem in the U.S., but also in large parts of Latin America, parts of Asia, parts of Europe, and even the parts of Africa where we were able to measure it. So in many places you can see are also gray where we don't even have measurements. So this is a significant problem, antibiotic resistance, and it's not just a U.S. problem, it's a global problem. And while this is mainly about antibiotics, this talk, I just want to mention the fact that antimicrobial resistance, it does not just mean antibiotics. We also have tuberculosis, which is a bacteria, but it's usually not considered when talking about antibiotic resistance. You have malaria, so those are parasites that have, you have significant resistance problems in treating malaria infections worldwide. And HIV and influenza with also significant problems with resistance. So this is sort of a common thread across all of these sort of anti-infectives, that you have problems of resistance and how to deal with them. So this is just a couple final words on sort of the problems of antimicrobial resistance. This is from the UK's review on antimicrobial resistance. And they estimate that right now there's about 700,000 antimicrobial resistant infections in the world yearly, and that by 2050 this could increase to as much as 10 million, making it significantly greater in terms of the scope than cancer, cholera, and other major problems that we consider issues now. And they also tried to estimate the economic cost of that. There's a pretty wide range on that, but the total GDP loss that they're estimating could be as high as $100 trillion. So there's a major problem with antibiotic resistance, and the problems stem from numerous issues. Largely, they stem from use. So one of the big things we have now is that in many parts of the world, you're having increasing incomes and increasing access to antibiotics. And that's really good because it's saving lives. But they're not a good substitute for public health. So this is data from CDEP from a paper in the Lancet, which shows growth in global consumption of antibiotics between 2000 and 2010. And you can see that the U.S. may have gone marginally down a little bit, and Europe, but mainly this is just because we're looking at the comparison between 2000 and 2010. And 2010 was a slightly odd year because you actually had no flu that year, really, in the U.S. The flu came through in 2009, if you remember, from the global pandemic, and then came through again the next year, not until the winter of 2011. So you didn't have a big flu season, and unfortunately, flu season is often highly correlated with antibiotic consumption because people treat the flu with antibiotics, which is not really a good thing. And so you can see that other than some sort of small declines in those areas, much of the rest of the world has saw big increases in antibiotic use. And again, these gray areas are places that don't have data. And you can see that this problem is increasing, antibiotic consumption is increasingly large in developing countries. So you have French West Africa, Brazil, China, India, and Pakistan have all had pretty large increases in the amount of antibiotics in total they're consuming over time. And these numbers have actually just grown since 2014. I have just recently got new data on that, but I have not been able to make the new slides yet. And you can see that those numbers are now approaching, in some cases, and are above places from the West. Right? So Pakistan now has antibiotic consumption per capita that rivals the U.S. and France. And India is increasing and nearing towards where Norway is. So these middle-income and low-income countries, which have not used antibiotics as much as sort of the Western countries have in the last 10 years, are now increasing their use because they have increasing income in order to access those drugs. And this isn't just for sort of basic drugs like penicillin or amoxicillin, but it's for things like extended spectrum macrolide use. So that's increasing in places like Brazil and India. We also have carbapenem use, which is increasing. So this is increased significantly in the U.S. hospitals, but also in other hospitals in developing countries, such as Vietnam and China. But we also have carbapenems that are sold on the retail market, and this is primarily in developing countries. Interestingly, this huge jump in use in India is related primarily to pharopenem, which is a newer carbapenem. Well, it's actually not that new. It was approved in Japan, but it's not approved for use in the U.S. and Europe at the moment. So that's why you don't have these big increases. But it's a cheaper carbapenem that's available as an oral formulation. So the reason these countries are increasing their use of antibiotics is because bacterial diseases are still major killers in developing countries. And this is primarily, again, partly because of a lack of access to antibiotics. On the x-axis, you have the increasing deaths from children, number of deaths from children due to pneumococcal, and on the right, you have the number of children under 5 years. And you can see that while India and China have made some progress, so they're not way out on the end in terms of deaths, they're still pretty high in deaths and account for a huge number because of the large number of children they have in those countries. The problem, though, is that some of the issues related to antibiotics and what we're asking them to do is not what they are theoretically intended to do. So this curve shows the disease mortality in the United States. You can see up here at the top point, this is the influenza 1918 pandemic, but you can see here that the mortality rate, so this is the mortality rate in the U.S., has been dropping over time. And it takes until 1940s till you get to the first use of penicillin. The mortality rate is already at under 200 per 100,000 already, and you can see you get under 100 before vaccines even started to be introduced. So this shows that there's a lot that can be done to reduce mortality rates that's not just related to antibiotics. But unfortunately, in many countries, you can see here, Sub-Saharan Africa and South Asia have much higher mortality rates than the U.S. does when they introduced penicillin, but yet they are increasing use of antibiotics rapidly. And in some cases, in theory, I guess, using it as a substitute for immunization and infection control and or water sanitation improvements. So there's a lot that we're asking of antibiotics that we shouldn't be asking of antibiotics to do. So I've told you a lot about the burden of antibiotics, and I've told you a lot about how antibiotic use has been increasing both in the U.S. and worldwide. And what I'm going to show you now is how these things are related. So this is data from Europe, and you can see on the bottom you have all the European countries, and their rates of antimicrobial use is on the y-axis. And if you look, this is then overlaid now is drug resistance. So this is outpatient use of penicillins on the x-axis, and percentage of non-susceptible penicillins isolates on the y-axis. And you can see that the Netherlands, which has the lowest rate, is all the way down the bottom, has the fewest resistant infections, and France, which is all the way at the other end, has some of the highest rates of resistant infections. So there's a strong relationship between the use of antibiotics, even on the scale of just a country, not just worldwide. This is from the U.S., and you can see on the left is antibiotic use, which goes up and down. And so you can pretty much pick out the peak of every winter, pretty much also consistently close to the peak of flu season every year. And you can see that the amount of antibiotic use varies dramatically between the summer and the winter. And if you plot that against data for resistance, you can see that resistance actually changes on the same sort of time scale and almost as rapidly as the use of antibiotics does. So use of antibiotics is highly related to resistance of antibiotics. And so the questions are sort of how do we then go about dealing with these problems of the global burden of resistance, both in the U.S. and elsewhere. So there's a number of drivers of antibiotic use that relate to incentives and behaviors of patients, physicians, pharmaceutical companies, payers, and the healthcare institutions. So we'll start with the patients. We've all had children who have needed antibiotics, or we have needed antibiotics, and what we found and what a lot of people have shown is that expectations of patients when they walk into the doctor's office matter for whether or not they're going to get a prescription. Patients are more likely to get a prescription if they expect antibiotics. And conversely, physicians are more likely to give a prescription if they believe a patient expects antibiotics, regardless of whether the patient expects it. Right? And so it turns out that physicians actually aren't very good at knowing whether patients expect antibiotics, but if patients do expect them, then they're more likely to get them, even if they don't verbalize that. So what drives these patient expectations? So the major common idea that is propagated by the CDC and by many doctors is that patients just don't know the difference between bacteria and viruses. They're the same thing. So if you look at most of the literature and you look at most of the education for patients, it's mainly around the fact that antibiotics are good for bacteria but not good for viruses. Well, it turns out we've done a study, and it's actually, there are a number of other possibilities in terms of how people think about antibiotics as to what drives their expectations. So one is this idea of why not take a risk? So I don't know if antibiotics will make me better, but it's better to be safe than sorry, so I should take them. And it turns out, and there's a couple others, prior knowledge. so I got better the last time I took antibiotics. The WebMD idea, which is someone, either the internet or a friend, told me that antibiotics will make me better. Trust, so I trust the doctor to give me antibiotics if I'm sick. Seriousness, if the doctor takes me seriously, they will give me a prescription. And the expectation that I like to call veni vidi vici, that I came here to the doctor, so I should get a prescription. So it's the only thing that sort of makes it worth me having come to the doctor. So we actually tested all of these expectations. It turns out that basically everybody, from physicians and patients, have the dominant idea is this: why not take a risk? So this is motivated by this psychological theory called fuzzy trace theory, which basically has the idea that patients think in two manners, either verbatim, so that is 1% of antibiotics will be useful, versus gist-based, which is only a few antibiotics will be useful, or antibiotics will only be useful a little bit of the time, right? So it's this idea of how people think is they actually rarely think in verbatim, but they usually translate verbatim into gist. So when I say 1% of antibiotic use is not effective, some people will hear that as not very much. Some people will hear that as, well, I must be in that 1%. And it's how people perceive those numbers. But basically the why not take a risk idea is that people will stay sick for sure. So people have two options. Either they're going to stay sick for sure, so they're going to avoid taking antibiotics, or maybe they'll stay sick, or maybe they'll get better by taking antibiotics. So given those two options, because that's basically, in essence, how people are thinking about antibiotics, well, they will generally prefer to get better over staying sick. So they're generally going to expect antibiotics. And the underlying assumptions from those two options and those two ideas, that what motivates this is that there is some chance that antibiotics could make them feel better, which is true. There's a chance that what they have might be bacterial in nature, and that antibiotics are essentially harmless to the individual. So there's basically no harm to taking antibiotics. As we know, antibiotics are not entirely harmless. So they can cause a lot of significant secondary infections like C. diff. They can also cause serious problems in terms of anaphylactic shock or other allergic reactions. They're actually one of the most common reasons people visit the emergency department for drug interactions or drug reactions to taking a drug. So there's a lot of possible problems. And then, of course, the one that we're talking about today, which is antibiotic resistance. So it's a major problem in terms of the global problem in terms of antibiotic resistance, but it also, taking antibiotics can predispose individuals to being more likely to get resistant infection. So what that suggests is that in terms of how you look at patient expectations and how you try to modify patient expectations, this paradigm suggests that some of the literature and some of the initiatives to change people's expectations and behavior regarding antibiotics may be based on not the right model of the way people are thinking. And so we've got more research going on in terms of how to look at that and how to more appropriately respond to how people think and expect regarding antibiotics. So in addition to patient expectations, there's socioeconomics makes a big difference. So we've got some work, and a bunch of other people have done some work which go all the way back into the 70s, which was like a RAND health insurance experiment, which showed that patients that get health insurance are more likely to get prescriptions for antibiotics. And that's partly because they're more likely to go to the doctor, and it's partly because, so it's an access issue, and it's also partly because they're more likely to fill prescriptions that they get because they have health insurance. We've also shown that if supermarkets and chains have occasionally run promotions for free programs related to antibiotics, and we found that that also increases the use of antibiotics and increases the use of antibiotics for the ones that are given away free relative to other ones. We've also done some research in terms of looking at access, and patients that are poorer in the U.S. socioeconomically are less likely to go to the doctor, obviously, and so they're less likely to get prescriptions. So again, another factor that drives antibiotic prescribing. There's also sort of in the doctor-patient interaction, some people who think that legal ramifications related to how the physician may or may not be sued for not providing antibiotics may also drive some of their decision-making regarding antibiotics, though there's less clear evidence for that. But there is some pretty good evidence that physicians get paid to some extent based on how many patients they see, and there is some evidence that they are more likely to prescribe if they think that patients might not come back if they don't prescribe an antibiotic. So there's things that can drive antibiotic use that may not be related to disease, but may be related to other factors around the question of the demographics or physicians' economics or the patient's economics. And what this all gets to is the fact that largely there's a big gray area. A patient comes in, and the doctor may or may not know if they have a bacterial infection. And that gray area is a big question. and because we don't have really good sensitive tests that can tell us for sure whether or not somebody has a bacterial infection. So that's sort of at the patient-doctor level. At the hospital level, the hospital has incentives. They actually may use antibiotics as a substitute for infection control. So it's easier to treat an infection than, because you can just write a prescription and insurance pays you back for that, than it is to do infection control, which often is not paid for. So hospitals often can have incentives to actually overprescribe antibiotics. And then pharmaceutical companies also have incentives, the primary one being patents. And so here you can see the black line is Zithromax, and the dotted line is azithromycin, which is the generic form of that. And you can see that the patent expired right there, and immediately generic use increased, and in fact, sort of overtook the amount of original non-prescription drug use that was being prescribed. So, and if you saw from the prior slide, some of that got taken with amoxicillin. So overall, it actually may or may not have increased antibiotic use. So patents can play differing roles, but pharmaceutical companies have very little incentive in terms of managing resistance because their patent expires and then they don't get any money. So I'm going to talk about an economic concept which is called externalities. And externalities are things that occur that are indirectly related to the actual action you're taking. So there's a positive externality from taking antibiotics, right? So this is a good example. If you take an antibiotic, you're going to get better if you have a bacterial infection, and you're going to be less likely to transmit that disease. So that's a positive externality. Unfortunately, the negative externality, which is the topic of today, is resistance, right? So the more antibiotics you use, the greater the selective pressure placed on bacteria to evolve, and the faster you're going to get resistant. Unfortunately, the big problem is that in the absence of economic incentives for any of these individuals, hospitals, or companies to take account of the negative impact of the use of antibiotics on social welfare, right? So we're not actually taking any account of negative externalities. And this is similar in many ways to gasoline or many of the other natural resources where we don't take into account the negative externality of using oil or using carbon. So now I want to get to the fun part, which is explaining to some extent what can we do about all these things, right? And unfortunately, there is no silver bullet. So there's no silver bullet for maintaining antibiotic effectiveness. There are trade-offs to every approach. So the two main mechanisms for maintaining antibiotic effectiveness in the long term are conservation. So these are things to keep antibiotics working over time, or innovation, or developing new antibiotics. But unfortunately, these two approaches are linked in a negative feedback loop. So if you develop new antibiotics, that puts a downward pressure on conservation to maintain antibiotics that we have already, and vice versa. So what are some of these efforts to control things, right? So the first is conservation. So we'll start on that side. And so antimicrobial stewardship is a big issue. So getting hospitals to reduce the use of antibiotics, that particularly unnecessary antibiotics, as well as a large number of outpatient antibiotic prescriptions are considered to be inappropriately prescribed. And we can do some of that by developing new clinically relevant tests that identify both the cause of infection and its sensitivity to common antibiotics. Unfortunately, currently most of those tests take at least 24 to 48 hours, which is not relevant for most doctor visits or an emergency department visit. And many times, even in the hospital, you have to start somebody on antibiotics and wait for these tests to come back. And then if they come back with the right information, you can possibly change their therapy, but that can be very difficult. So this headline is from an article which developed a test that can actually get down to about 6 hours. That's about the best test that's available in terms of looking for bacteria and the cause of an infection and its resistance in a somewhat clinically relevant time frame. But again, 6 hours is still not something that is relevant for a doctor's visit. Vaccines can also be very helpful. So new vaccines, so the strep vaccine has been very helpful in reducing rates of strep, both in the U.S. and around the world. And new vaccines for things like Staph aureus or other bacterial infections or bacterial pathogens would also be effective in reducing rates of antibiotic use. There are other things that we can also do to conserve antibiotics. One is combination therapies that target both the essential functions and the resistance factors. So that's something like amoxicillin clavulanate, also known as Augmentin. We can repurpose old drugs to optimize dosing levels and duration and the route of administration. For example, optimize dosing of colistin to reduce toxicity and improve efficacy. And we can also prevent resistance by protecting non-target bacterial flora during treatments. So these are things like probiotics. So getting back to this whole feedback between conservation and innovation, one way that we like to think about it is that antibiotics are like a natural resource. So this is an oil well, and oil has been in the news a lot recently because the cost of discovering new sources of oil becomes more expensive as the resource is depleted. It became much more expensive to develop shale, much more expensive than the old way, both because it's difficult to do and because of increased environmental regulations. But the more you increase incentives for producing more oil, which lowers the price, the less the incentives there are for things like renewables or for Priuses or other hybrid or electric cars. Similarly, new antibiotics are likely to cost more than existing ones because it's harder to discover them, and there's increased regulatory costs in terms of getting an antibiotic approved. But again, just like oil, subsidies for new drug development discourage efforts to improve how existing antibiotics are used. So just to talk a little bit about where we are in terms of the innovation pipeline, unfortunately, this is the graph that everybody likes to show in talking about this, which is the number of new antibiotic bacterial agents that have been approved in the last 20 years. And you can see it's been significantly going down. And although we've had a couple new ones introduced in the last several years, primarily targeted at MRSA, skin and soft tissue infections, we don't have that many in the pipeline. And you can see here's a graph showing on the top when new antibiotic classes were introduced, and on the bottom when resistance was discovered. And you can see that pretty much as soon as antibiotics are discovered, resistance emerges to them. And you can also note that there's a large period in here in which we have no development of antibiotics. And this sort of low period in terms of not developing antibiotics has resulted in us having very few new antibiotics being approved going forward. So while development of new antibiotics and conservation are linked in a negative feedback loop, we still want to incentivize companies to produce new antibiotics. We need new antibiotics. And so there's a number of ways that this has been looked at, right? So one is ways to decrease the cost of development. So this is through tax credits or grants or other mechanisms that can reduce or the cost to companies to develop them. The other way is to increase the income linked to producing new antibiotics. So you can do this by extending periods of exclusivity that a pharmacy company can sell a drug for. This could be prizes. So the most recent one is the GAIN Act in the United States, which gives an additional 5 years of market exclusivity for specific antibiotics that are targeted for infectious diseases. So in the last couple of slides, I just want to talk about some of the important questions. One that I like to ask is, do we really need those public subsidies for new antibiotic development, or will the market respond on its own? So this is a graph of the drug prices for different antibiotics. Penicillin cost about 1 cent in 1941. The most recent two drugs that have been introduced, linezolid and daptomycin, cost in the hundreds. So a pretty good return on investment. Antibiotics are really useful. If you give somebody who's dying from a bacterial infection antibiotics, you will save their life. So there's a pretty good return in terms of the cost of $155 to save your life. It's not so expensive. Compare this to Sibuleucel T. If anyone hasn't guessed, this is a cancer drug, slightly more expensive than antibiotics. And like many cancer drugs, is really only going to prolong your life by a small period of time, if anything, right? So many of them will only increase life by a couple months. Obviously, the goal is for significantly longer, but the costs in terms of what cancer drugs bear and what antibiotics bear in the market are very different, and potentially we want to increase the costs of antibiotics to make them more attractive to companies to produce. So the other things that we don't really know the answer to is what are some of these impact of public subsidies for new drug development on stewardship. So we don't really know what's the impact of producing these new drugs or creating incentives to produce new drugs on stewardship, right? From the theoretical perspective, this should reduce efforts for conservation. And there may be some sort of mindset around physicians that they're less likely to conserve drugs because they know new antibiotics are coming down the pipeline. But we don't actually know a lot of that. And how can we change the rules of the game to incentivize appropriate use of new and existing antibiotics, right? So we don't really know how best to do that. And how do we best balance concerns of access to antibiotics? So we want people with less access to antibiotics to have more access to them, but we want to balance that with the concerns that we have about resistance. So that's all I have. Thank you